Hello everyone and welcome to CK Med. My name is Clark and I'll be taking you through head and neck second video today.
So to start things off, there's embryological formations known as the pharyngeal arches, and I'm sure you've heard a few of these as far as the heart and blood vessels go. But here we're going to be talking about some of the pouches and grooves and arches of the first few, 1, 2, 3, and 4. So I'm not going to go into super detail as far as this video. There will be a further video that goes into a little bit greater pictures, as well as a supporting link video to Anatomy Made Easy for the pharyngeal arch derivatives. It's amazing, amazing resource, and you have to watch that 25-minute video. So definitely check that out. I'll be posting that on our page in coordination with this video. Definitely watch that. So some of the basic things is trying to understand what on earth am I looking at in this picture, and trying to figure out how this can form certain congenital problems. And so when you're looking at yellow, you're looking at endoderm. If you're looking at blue, you're looking at ectoderm. And so what does that mean? Anything in here is also mesoderm. So this is our three embryological layers that you've probably heard a million times, even throughout biology, as things are derived from. So from these different areas, so all this yellow is going to form these different pouches. This is known as pouches, is from endoderm. Ectoderm forms clefts, or also known as grooves. They have two names. They usually refer to them as grooves, but they can be called clefts as well. So pouches are inside, like a pouch inside, right? And then clefts or grooves are outside. So you have a few of these different things. The first arch that's formed in the middle of here, the mesoderm, is going to form multiple structures, and this is all having to do with your mandibular stuff. So it's going to be your trigeminal mandibular branch for motor, your mastication muscles, everything having to do with that. Your mandible is all going to be formed from pharyngeal arch 1. So if you just think of first came man, M-A-N, and then second came female, so this is going to be your facial branch. So facial, F for female, is going to be a lot of the different facial expression muscles, and some of the bones having to do with facial things where the facial nerve passes through. So some of the things inside the ear, as well as other portions. So this is our facial arch. We also have in between the first and second arch, we have a pouch and a groove. So the first groove and the first pouch come together and they form this little membrane. This is known as your tympanic membrane. So I wonder what these are. So from the inside, we have this eustachian tube that comes into your inner ear. And outside, we have this little outer stuff, and this is your external ear canal. So if you stick a Q-tip in here and clean out your ears, you're going to touch this membrane made from the first groove or cleft and first pouch. So that's how the ear stuff forms. From the second pouch, you're going to form a bed for your tonsil. This is where your tonsil can grow from the pouch. What also can connect to this are the grooves 2, 3, and 4. So grooves 2, 3, and 4 form what is known as a cervical sinus. A cervical sinus means that it's open. And cervical cyst means when this encloses into a sac. So this is actually described wrong here. This is actually cervical cyst. But cervical sinus can connect from outside into this nice little sinus. If this then reaches over and attaches to the second thing, you have this nice little connection from outside to inside. And this is known as a branchial sinus, or branchial fistula is connecting from here. If this remains patent just like this, you have branchial sinus. And if it closes off and leaves a big bulge that pushes out here, kind of just anterior to your sternocleidomastoid, lateral to the midline of your throat, meaning it starts to fill up with fluid in here, then that's going to be known as a cervical cyst or branchial cyst. So these are all branchial things. Branchial fistula, branchial sinus, and branchial cyst is how those are formed, all from this cervical sinus or patent cervical sinus. Your third and fourth pouches derive different organs. So your thymus is derived from your dorsal your ventral portion of your third pouch. So thymus is developed from there, and that's important for the purpose of making T cells for your immune system. Now these top yellow ones of third and fourth are going to make your parathyroid. So the fourth actually makes the superior, and the third makes the inferior portion, because they flip and spin upside down, of your parathyroid gland. Next is going to be your ultimal branchial body, which are little tiny cells inside of your thyroid gland that comes down. And then up around in between here, so pretend we can spin this around and flip it, so endoderm, so we have a nice tube inside the mouth, kind of. In here we'll have little tongue buds that make the tongue, and we'll make our thyroid gland, which descends. And then all these parathyroids get stuck into it, little pieces like this. Ultimal branchial have C cells that go into there. All those little pieces go together and form your thyroid, parathyroid, and your C cells, also known as your calcitonin secreting cells or your parafollicular cells. Those are important for that. Those all make that kind of chunked organ. So thyroid gland from up here. It's not actually from any of these things. It's just from a thyroglossal derivative, and then it comes down and forms with the parathyroid from third and fourth, and ultimal branchial for your C cells. That all makes that thyroid important structure. Now with those coming descending, there's sometimes a little connecting duct between this thyroid and the tongue. If that holds, it's like a rope. Just imagine a rope. So if a patient swallows, this thing is midline. If it swells, if it forms a cyst, this is known as a patent thyroglossal cyst. And this is a midline structure that moves when the patient swallows. And we'll get to that in just a second. Here's all the derivatives. I'm not going to go into that. You can definitely check out our file for that information, and that does that as well. So here we have our lingual thyroid or thyroglossal duct cyst. Midline cervical cyst also is another name for this. So this midline right here, patient when they swallow it moves up and down, and this is just the foramen cecum is what that is called, or remnant of that. And then branchial fistula or cyst or sinus is this little pouch over here. If this leaks out, then it's going to be a branchial sinus or cyst. If it leaks out and connects all the way up to your tonsillar bed, it's going to be a fistula. If it's just a bulge like this child has here, then it's just going to be your cyst. And that's failure or obliteration of cervical sinus, second pharyngeal groove, and pouch. Also your second, third, and fourth, which is your cervical sinus. And it appears right on the anterior border of the sternocleidomastoid, innervated by cranial nerve 11, just to recap. So a few other things that are important are going to be your cleft lip and cleft palate. So before we we'll come back to this in just a second. So let's go ahead and describe how this embryo actually is formed. So what happens is you actually have, as your face forms, it forms from 5 prominences that start to fuse together and form. One that forms like your nasal prominence comes down and forms this part of your palate, and one that comes from your maxilla, your cheeks, that come to form all the rest of this portion of the palate and these sides of the lip, as well as this nasal part was the middle part of the lip. And then your mandible, which is your lower jaw. If some of these don't fuse together, then you'll start to have either cleft lip, cleft palate, or both. And they can be bilateral, they can be midline. If it's midline, then that's a failure of the nasal or intermaxillary segment to form properly, or failure of the fusion of the middle or medial nasal prominences. Lateral nasal prominences with maxillary is going to form your oblique, and then failure or fusion of the primary and secondary palate is going to lead to cleft palate. So if we look at these, you can see unilateral and bilateral cleft upper lip, and it's failure of the maxillary process with the intermaxillary segment. If you have median cleft, fusion of the medial nasal processes did not work. Anterior cleft lip, failure of fusion between the primary and secondary palate, and that's cleft palate I mean. Posterior cleft palate, and that's failure fusion of the lateral palatine processes or maxillary segments alone. Oblique facial cleft, that's failure of the maxillary process with the lateral and medial nasal processes. And it looks just like this. This is what the oblique looks like. It goes right up to the lacrimal gland. This is unilateral cleft lip, and this is just cleft palate, as you can see in the back. So Now, other congenital defects. One known as holoprosencephaly. This is due to failure of sonic hedgehog. Whenever you hear the word sonic hedgehog, make 10 stars next to it for every course you ever hear this in, okay? This is high yield, especially in genetics. So holoprosencephaly is when you have too little of sonic hedgehog, which sonic hedgehog allows for proper separation and division of different processes of growth. So your eyes need sonic hedgehog to separate. So if you don't have enough, your eyes won't separate. This can lead to one fused eye, or what is known as cyclopsism. Also, it doesn't divide your forebrain because your forebrain needs it to separate as well. And you'll have one single fused ventricle, as you can see right here. Next is Arnold-Chiari malformation. Now, this was on our exam, and as it was for many other exams, so definitely high yield. This is inferior displacement of cerebellum. So if your cerebellum starts to shove down into foramen magnum, it can damage cranial nerve 9, 10, 11, which are right on that medulla there. This is known as Arnold-Chiari malformation. Treacher-Collins syndrome is pharyngeal arch 1 syndrome, or the first pharyngeal arch. And this is usually micrognathia, conductive hearing loss. This is one that gives it away. And drooping lower eyelids. So drooping lower eyelids, not upslanting. Because upslanting you're going to be seeing in Down syndrome. This is drooping lower eyelid. And this is what Treacher-Collins looks like, just right here. They have very small little tiny ears and very tiny jaw. DeGeorge syndrome, or Catch-22, or 22q11. This is a deletion on the 22nd chromosome, Q-arm 11 position. This failure of migration of the third and fourth pouch. This is endoderm, third and fourth pouch. So there's going to be a lot of problems having to do with parathyroid. So they'll have hypocalcemia and stuff like that. So definitely recognize different description features of this guy. Robin sequence, this is also on our exam. Micrognathia leads, so micrognathia means small jaw. So this is a sequence. This is something that when one thing goes wrong, it leads to problems with the other things. So micrognathia, so small jaw pushes the tongue backwards that's developing. If the tongue is pushed backwards, then it's in the way of the palate trying to form. So when the palate tries to form, it can't fuse because the tongue's there. So that leads to cleft palate. So these are the three sequences. Small jaw pushes the tongue back, tongue's in the way so the palate can't fuse. And that's going to be known as Robin sequence. Ankyloglossia, this is abnormal lingual frenulum, which you can see right here. Patients have difficulty suckling and stuff like that. Simple, all you have to do is laser that off. Now there's a ton of different one of these. I'm not going to go through all these. Definitely just check out our file and read through these, make a Quizlet or flashcards or something. But definitely recognize this red one down at the bottom. High yield, yellow, gray teeth in infants from tetracycline. Don't miss that. If you have congenital cataracts, you're thinking rubella. That's something that's very high yield. Rubella right here. That's a viral infection. And all the other ones are not as high yield, but definitely check them out, especially coloboma. They showed an image of this and asked what it was from. So that's closure of the retinal fissure. I'll be going into embryology of the eye development a little bit in a later video. So the auditory meatus and eustachian tube. We talked about some of the basic structures, how they form embryologically. So what are they innervated as far as outside here? So auricular temporal is the branch off of V3, or your mandibular branch of your trigeminal. This does some innervation outside in here, as well as greater auricular, which is cervical nerves, as well as 7 and 10. So a lot of these do these. If a patient puts something in their ear, like a Q-tip, and they cough, you're talking about vagus. Don't just skip everything else and just go straight for vagus. Route of infection, how this is going to definitely come up for your test. We actually had 2 or 3 questions on our anatomy exam on this. How does infection spread to the inner ear or the middle ear? It's via this eustachian tube. So pharyngotympanic or eustachian tube is a first pharyngeal pouch, which we talked about that. And the innervation sensory for that is going to be cranial nerve 5, V3. And so Most likely, as far as pain that's caused in here, is going to be your glossopharyngeal. Glossopharyngeal is going to innervate sensory for there. So definitely recognize that glossopharyngeal, when you have inner ear infection or something like this, otitis media, why is it painful? It's going to be pain due to glossopharyngeal. Hyperacusis. So this is sensitive to high sound. This is usually due to paralyzation of the stapedius muscle. So stapedius allows for, or your tensor tympani from cranial nerve 5. These hold the tympanic membrane tight, so when there's loud, intense sound, it kind of dulls it, so it's not as sensitive. But if you paralyze those muscles, you can't compensate for that loud sound, so they're going to be very sensitive to it. And that's pretty much it for that. I'm not going to go into super detail as far as this picture, but this is kind of a nice picture to look at what it looks like inside the middle ear and what's on each of the walls. So the middle ear cavity houses a lot of different things, such as the facial canal, where the facial nerve runs. A chorda tympani passes through here, right behind the tympanic membrane. So you can damage that if you pierce that tympanic membrane. And then this is a place where you can injure any of these nerves and start to lose some of those deficits. So definitely familiarize yourself where things pass through. Definitely focus yourself on this one. This is very high yield as far as facial nerves and chorda tympani, taste loss, and stuff like that. What will you lose if you damage something inside the middle ear? Now, as far as sensory on the outside of your ear and the temporal side of your skull and inside your ear canal is innervated by several nerves. So branches of your glossopharyngeal is going to do your middle ear. Vagus nerve will, in addition to branches off your facial, known as nervus intermedius, and your cranial nerve branches of greater auricular, also going to do a little bit of sensory through here. Auricular temporal nerve off of facial as well will also do some of the inner ear or external auditory canal, which where you stick your Q-tip in. Outside of the ear, you have your greater auricular, which is kind of below your ear and behind it, and then above and behind is your lesser occipital. Not super high yield, but definitely understand that if someone shoves a Q-tip in their ear to clean their ear and they cough, then that's going to be your vagus nerve that's innervating that. So now epistaxis, or nosebleed, and paranasal drainage. So this is important because you have what is known as Little's area or Kesselbach's area. I have two names for this. And this is due to a meeting anastomosis point of the anterior ethmoidal artery, which is off of your maxillary, as well as your superior labial and sphenopalatine, which are also off of maxillary. So these blood supplies, when they meet together in anastomose, this is going to possibly cause, if dry, a nasal canal, anterior epistaxis. So this is anterior nosebleed. Now the posterior is more involved with necessary for blocking. You need procedure to be done to stop posterior bleeding because it bleeds greater. But that's going to be mainly from different branches of your maxillary artery or sphenopalatine. So that's really the only importance as far as epistaxis is just that anastomosis at the Kesselbachs and their branches off your maxillary, as well as also your facial too. And then we have our different sinuses. So we have several sinuses, and they drain in different areas. So you have your frontal sinus, which is right up here. So you have your frontal sinus here. You have your sphenoid sinus, which is right under your crista galli, which is where your pituitary gland sits. So your pituitary gland sits right in here. And sphenoid sinus is right here. So if you break through the floor of your anterior fossa or your crista galli, you're gonna, or I'm not sorry, not crista galli. What am I talking about? The place where the pituitary gland is. If you break through that, it's going to be your sphenoid sinus. This drains right out into the nasal canal alone, and that's going to be also in coordination with the superior ethmoidal sinus. So superior ethmoidal sinus also drains into, or this is where it drains into. Now into your middle ethmoidal sinus, so this is superior, this is middle, and this is inferior. Your middle ethmoid sinus is going to drain into this, the middle nasal sinus. So this is superior nasal meatus, middle nasal meatus and inferior nasal meatus. And your middle ethmoidal is going to drain right into your middle nasal. Also, you have your frontal sinus and maxillary sinus drain right in here. So frontal goes through, you can see this kind of tube drain out right here, as well as the ethmoid bullae drains out right here. The inferior nasal meatus is where your nasal lacrimal duct actually ends up draining. So this is nasal lacrimal. So when you cry and you push it on the corner of your eye and you feel that fluid drip into your nose, that's going to be your nasal lacrimal duct. Now, onto lymphatic drainage. This is something very basic. It's not super complicated. Most of all your face is going to follow kind of the general direction. So you have some mental glands. So your chin and lower lip are going to go down to your submental, because your mental is your chin. It's going to go into submental and then eventually drain up into submandibular and then jugulodigastric. Now all the rest of these will drain into jugulodigastric, except occipital. Occipital is going to skip that and eventually end up in the deep cervical superficial chains, which are here. You're going to be able to analyze these different guys as far as feeling them in lab for physical exam. So don't get too bogged down. It's not super complicated. Now a little bit about the tongue. So hypoglossal nerve, your cranial nerve 12, is going to be controlling all your intrinsic muscles of your tongue. It's going to be your genioglossus, your genioglossus, depression and protrusion, styloglossus, hyloglossus, and palatoglossus. So those are all those extrinsic muscles as well as your intrinsic muscles of your tongue. However, the one exception to this is that palatoglossus right there. See how it has that X? That's going to be your cranial nerve 10. So vagus actually controls your palatoglossus, which elevates the tongue and depresses the soft palate. But all the other ones are going to be your cranial nerve 12. Genioglossus, styloglossus, and hyoglossus. Glossus just means tongue, so when you see that, except for palatoglossus, know that it's cranial nerve 12. If you have damage to cranial nerve 12 and you try to push out your tongue, it's going to deviate towards that side or ipsilaterally. Why is that? Just to pretend it's brakes. So normally you push your tongue outward and it goes straight. However, if you put brakes on your right side, what happens is your tongue's going to start to go right, because it gets stuck as you're pushing out the left side of your tongue. That's exactly what happens when you damage your right cranial nerve 12. This is often due to damage to your submandibular duct. Lingual nerve is prone to injury when you do this as well, because they cross over. They make a little cross, and you'll see that in lab. It's pretty cool. And that's a high yield for lab exams. Now a little bit about pharynx innervation. So you have your nasopharynx, oropharynx, and laryngopharynx. So nasopharynx is up here. And remember, we have our maxillary nerve that comes out to this part of the face. So it's going to be your maxillary nerve, V2, trigeminal part 5. Gland is going to be your facial nerve via the greater petrosal nerve, parasympathetics. Your oropharynx, sensory, is going to be your glossopharyngeal. So glossopharyngeal does all this yellow section here. Also does part of the eustachian tube and your middle ear. So if you have otitis media, it's going to be glossopharyngeal. Also innervates one muscle, it's going to be palatopharyngeus. Palatopharyngeus is the name of that muscle that this does. Glossopharyngeus. So then you have the gland that does the secretion in this area is going to be your vagus. Also does the motor of your palate too, is what vagus does. Now laryngopharynx. So laryngopharynx has innervation from cranial nerve 9, glossopharyngeal, and 10, and the gland's going to be from your 10. So that's this whole area here. So uvula and tongue deviation. So this is one of your gag reflex tests. So the afferent for this is going to be your glossopharyngeal. is going to be testing that sensory. If you touch the sides of their palate, the sensory goes up and then again re-innervates cranial nerve 10, your vagus, to control the motor to lift up your palate. So you have a person say ah, or if you poke them in the back, they're going to gag and their palate's going to lift up, removing them away from what just touched them. And that's pretty much how that works. If your uvula is deviated to the left or right, that's going to be you want to try to figure out where that is. So if he deviates to the left, that means if you're looking at your palate, just imagine the muscles are pulling on either side. So here's your uvula right here. If you're pulling on either side, but now you weaken this side, cross and cross. Now this is going to pull to the opposite side. So wherever the damage is as far as vagus goes, so left vagus means that your uvula is going to deviate to the opposite side, to your right. And tongue, again, like we said, is ipsilateral. So left cranial nerve 12 damage, it's going to deviate to the left, right, and right for tongue. That's one of the high yield questions there. Gag and cough reflex, we just discussed that. Definitely check out and remember that sensory is going to be from glossopharyngeal and your efferent or motor is going to be from your vagus. Now in the larynx, there's quite a few specifics here that are very important. So vagus really does everything. Vagus does everything for your larynx and your pharynx. And it does it in different ways. It has specific small branches known as your superior laryngeal, your external laryngeal, and your internal laryngeal branches, as well as your recurrent laryngeal. So your superior laryngeal is one nerve that comes off with two branches, your internal laryngeal and your external laryngeal. Your internal laryngeal is accompanied by your superior laryngeal artery, and they go into piriform recess and past the epiglottis, and it does sensory and blood supply, sensory above the vocal cords. So internal laryngeal is going to be sensory above the vocal cords. Okay, this goes into piriform recess. If you get a fishbone stuck in there, it can damage internal laryngeal, losing sensory above the vocal cords. External laryngeal does motor for your cricothyroid and pharyngeal constrictor muscles. And that's your external laryngeal nerve. Recurrent laryngeal innervates for all the vocal muscles. If you damage this, either through heart surgery, something like that, as we talked about in heart, how the recurrent laryngeal goes down and then loops back up into the pharynx, this can lead to hoarseness of the voice. What these do is innervate the posterior cricoarytenoid muscles, which abduct the vocal cords, opens the rima glottis, and if you have cancer in there, it could be limited metastasis. So tracheotomy or tracheostomy versus cricothyrotomy or cricothyrotomy. So tracheostomy is a procedure that puts a lot of things to risk as far as blood supply. And this is really important for the purposes of helping someone survive when they're having problems such as respiratory obstruction, such as choking or something like that, where you need to get access straight to your trachea. This is a procedure that a doctor needs to do in the hospital. So tracheostomy can possibly damage the thyroid IMA artery, anterior IMA. This guy right here, because it passes right in front of here. So if you pierce right here, obviously you can damage this artery and have a lot of bleeding. So remember, this is thyroid IMA artery. Left brachiocephalic vein also is possible to be damaged, and you want to go between the third and fourth cartilages of this. Cricothyrotomy, so cricothyroid artery is possible to be damaged. You just put an incision through the cricothyroid membrane, which is right here. And that's pretty much it for those guys. The last thing is going to be your thyroid blood supply. So you have your thyroid gland, and you have venous structures and arterial structures for this. So you have your superior thyroid, which is off of your external carotid, and inferior thyroid, which is off your thyrocervical trunk, which when we discussed upper limb and anastomoses, that's where that came in. And then your veins, you have your superior thyroid, your middle thyroid, and inferior thyroid. And so these drain into different regions of the jugulars as well as the brachiocephalic.
MedSchoolTutors!
You're at SGU and you're thinking about Step 1. There are so many resources and so many opinions. How do you know which path to take? You've worked so hard and you deserve to match into the specialty of your dreams. MedSchoolTutors has helped nearly 1,000 SGU students get their best scores on their CBSE and USMLEs through highly personalized one-on-one tutoring and individualized advice. Our SGU students see average Step 1 score increases of over 30 points when working with us. Scores that are their tickets to competitive residency spots around the country. Schedule your free phone consult today to be matched with your tutor. MedSchoolTutors. Get where you want to go.